Okay, thanks everybody. Thanks for joining us for this newborn screening panel today. We have several stakeholders who participate in newborn screening from different perspectives. And so the format is we will have just a quick introduction from each of our panelists, and they will just give a word or two about what newborn screening means to them. And then we'll have a Mentimeter to ask the audience what they think that newborn screening means to them. Then that'll be followed by a short overview of sort of newborn screening at the US, kind of the current situation and where potentially where it might be going. And then we'll have Suzanne Flynn tell her story with her experience in newborn screening. And then for the remainder of the session, we have some questions that we're going to ask our panelists to respond to. And then if you have questions in the audience, please go ahead and put them in the chat and we will address them as best we can. All right, so I'm Michele Caggana. I am a co-director for NIMAC. I also run the newborn screening program for New York, so this topic is near and dear to my heart. Sika Singh from APHL was supposed to be on in this session today and give that brief overview on newborn screening, but she was unable to make it, and so I'm going to cover that for her. Suzanne, do you want to introduce yourself? And then what newborn screening means to you, just briefly, and then we'll get into it.
Okay. I'm Suzanne Flynn. I'm a pediatric nurse and a mother from New York State. What newborn screen means to me is hope. It's a gift that gives you the information that you need to know about your children in order to monitor and intervene at the earliest possible time in order to ensure that they live a healthy life, that they get the opportunity to live a healthy life. So it has been a gift for our family.
You are on mute, Michele.
Myself unmuted since I'm in my office myself. Okay, next on my list, I have Dr. Shore.
Yes, that was beautiful. Thank you. What newborn screening means to me as a provider is a chance for every baby, no matter what their background, where they come from, to receive a test where they will have access to equal treatment if they do have a condition that needs our help. So it's identifying those kids early, no matter where they come from, who they are, and having the same start, an opportunity to start life with all our treatments and advantages and interventions for every child.
All right, thank you. Next, Dr. Tarini.
Hi, I'm Beth Tarini. I'm a pediatrician and a health services researcher. And through that lens, I see newborn screening as a system that serves patients and their families as the ultimate outcome from those two identities.
Thank you. Miriam?
Hi, I'm Miriam Schachter. I'm the program manager of the New Jersey Newborn Screening Laboratory. What newborn screening means to me is the ability to use science and technology to save lives and impact lives every day, and to do it for the youngest members of our population.
Thank you. And Kristen.
Hi, good morning, everyone. My name is Kristen Cruz. I am the newborn screening programs and birth defect surveillance manager with the Virginia Department of Health. And what newborn screening means to me is giving all the babies that are identified by a disorder on our panel the best possible outcome for their life.
All right, thanks everybody. So that's our panel for today. And we should have a Mentimeter link come up to be able to get feedback from the audience on how they feel about newborn screening.
Yeah, the link coming up in the chat right now.
Okay, it's there. We'll give everybody a minute or two.
Yeah, cool. And I'm gonna share my screen.
Okay.
So you can start seeing the answers as they come in. Let me know if you have any troubles accessing Hmm. So do you see the words? The
Mhm.
millimeter? All right.
All right. These are so much fun to watch. Linda says equity as well, also very important from a public health perspective. All right, so early intervention seems to be the most common theme, but we have, I like clarity, I like dedication. Great. We can save that, right?
Yeah.
I would like to be able to use that in the future. my own bias there, but okay. So I'm going to just kind of go over newborn screening from sort of the APHL New Steps perspective, and it'll, for those of you that aren't as familiar with it, hopefully it'll give you a pretty good background of kind of the state of the state here. So, sure. Can you see the first slides?
Yes, we can.
Okay, great. Oh, it's in the display mode, right? Is that okay?
Yeah.
Or you see
Yeah,
it?
yeah, we see it. Perfect.
Okay, because one screen has presenter mode and the other one does not. Okay, so again, this is Sika's talk, so I will try and do her justice. Advance the slide, that'd be good. Okay, so I added my name to her slide. I also do not have any financial disclosures. So this project is basically the approach we're taking is to talk also about New Steps. So it's funded by HRSA, which is the same federal agency that funds the Regional Genetics Network. And so you can understand how we all work very closely together. New Steps is serviced by APHL, the Association of Public Health Labs, and newborn screening programs really are active within the APHL newborn screening section. So the program is technical evaluation of programs, and it also provides assistance. And the overall goal is basically to keep applying continuous quality improvement to newborn screening programs so that they can be the best they can be. And New Steps provides tools and a springboard for collaboration between programs and all of the other newborn screening stakeholders. So when we think about newborn screening, we think, in the laboratory piece of the dried blood spot screening, which does screening for anywhere from 35 to more than 50 different conditions, but also there's screening for hearing at birth and critical congenital heart disease. So newborn screening programs are really sort of grounded in public health. They usually reside within departments of health within state programs, and it's sort of a system-based approach. So it's not only a laboratory, but there's also follow-up, and we look at outcomes and diagnoses and continually try and improve the testing algorithms. In the US, programs are generally state-based, and most have some ability for parents to opt out, but in most cases they are really mandated by some sort of public health law. And they're designed, as the Mentimeter showed, our goal is early intervention. So we want to find these kids before they become ill and give them treatment so that they have better outcomes, reducing morbidity and mortality. So you can think about newborn screening as sort of this whole population of babies wrapped in green. And we are looking for those couple babies that are actually at risk. So the idea is we take the entire population universally and we apply the screening program to them. And then at the end of the day, we find those couple infants who really need some sort of further downstream evaluation. And then from there, we refer them out to the medical community for diagnostic evaluation and diagnosis and treatment in cases where it is necessary. There are several phases when we think about lab testing and newborn screening in general. So we break them down as a pre-analytical, an analytical, and a post-analytical. So the pre-analytical stage involves sort of, telling the family about newborn screening, applying some education, collecting the sample, drying it, and then transporting it to the program wherever that resides within the state or in a region. The analytical piece is sort of the lab testing, right? We punch this, we accession the specimens, we punch them, we do the lab testing, and then we get some results, and then we apply some sort of interpretation. The post-analytic is actually the results report, whether they're normal or not. And then, as I said, the follow-up related to those kids who screen positive and need further evaluation or workup. One thing I want to emphasize is a lot of people think of newborn screening as a simple lab test, but there are many, many stakeholders. And if you only remember one thing from this session, both from our panelists and from this slide, is that there's many people that play a role with that family in the center and making sure that newborn screening programs run smoothly and that the babies get follow-up care and treatment as soon as possible. So people in the world of newborn screening might know the word RUSP, that stands for Recommended Uniform Screening Panel. And this is sort of a federal guideline. There's a federal committee called the Advisory Committee for Heritable Disorders in Newborns and Children, and they review conditions and it's a thorough process to determine whether or not a condition, no matter what it is sort of worthy and checks the boxes for newborn screening to be applied to a panel and then recommended that every baby in the US gets screened for it. So the way the process works, and this is a very short version, is they submit a nomination package, and this could come from advocacy groups, it could come from researchers, it could come from the newborn screening program and working with the researchers and parents. But there's a form online that you fill out, and you have to, it's not for faint of heart, but you fill out this nomination package. It gets submitted to HRSA, who then does a review and then hands it off to a work group who reviews the package for thoroughness and then creates sort of a summary that gets presented to the full committee. There's a 9-month period of time where the full committee, the condition review group, gets assigned it if the committee votes that, okay, this sort of preliminary overview was good. We want to see all the evidence about this condition and what the treatment and follow-up is. And so it goes to a vote. If they decide it goes to evidence review, there's a group tasked to do this, and they look at the literature, they talk to technical experts, they talk to public health about readiness to be able to implement screening for the condition, and they talk about physician specialists who treat children with these conditions and sort of what the treatment outcomes are. After that evidence review is complete, the group has 9 months to do all of this work. And then at that point, it goes to a presentation to the full committee and a vote to add it to the RUSP or not. If the committee votes yes, that they want to recommend that it gets added, a letter goes to the Secretary of Health and Human Services, and that individual has 120 days to make a decision. And so from the time that a package comes in through, it's about a year and change to determine. And of course, if the package isn't worthy or isn't complete, it goes back to the submitter at that point, all the way up at the top of that schedule. So usually newborn screening programs have sort of an idea of what is coming down the pike, but I just have put together this information to tell you there's different ways that states add conditions. So some are added via legislation, some are added by change to rules and regulations, and this it could be the Board of Health, the Commissioner of Health. Some states have newborn screening advisory committees. And there's like also the cost has to be factored in, and that's a big factor because some programs, as I'll show you, have fees, and an addition of a new condition may require an increase in fees, and that's a whole nother step in the process. Some states will just adopt whatever the RUSP gets onto the RUSP, and then others have sort of a framework for doing that, or a time frame by which, by law, they have to add the condition. So there's different sort of mechanisms for the additions. When we're looking at this on the kind of the grand scale from a programmatic basis, we have to look at the laboratory. We have to see, okay, do we have space? Do we have people who have expertise? Do I have to develop something totally new? I have to develop a method. I have to validate it for high throughput. Sometimes researchers will develop an assay and they've done 50 samples but screening programs screen anywhere from 1,000 or so a year up to almost, well, the double screen states screen somewhere around 800,000 a year. So it really has to be high throughput. We need reagents, a reagent supply. You may have to set up contracts. There's a lot that goes into that piece. Follow-up, you have to get your medical providers on board. You have to have algorithms for how you conduct follow-up. You have to integrate it into your workflow from the lab follow-up and obviously the IT standpoint. And you have to develop education for PCPs, hospital coordinators, families, and do translations as well. So there's a lot more than just, I have a lab test and I'm going to do it. Another take-home message. So what can impact that? One of the main hurdles for states is trying to get that overall approval in the first place. We kind of know what we need to do. We know the steps, but this first bar here can take quite a while in states. Program considerations are things that we are kind of used to doing, and there's a process. Sometimes we have to do fairly rigorous pilot testing in order to be able to do full throughput screening. If it's a brand new thing and we don't know much about it, you have to finalize sort of what your cutoff values are going to be. And remember, newborn screening is sort of looking at rare conditions. So you have to screen sometimes a lot of babies to get a single one that's positive and actually has the condition. So this is, can cause sometimes delays, sometimes in getting things started. And then the education piece, again, you do your research and you create documents. A lot of these things have to go through review on a state side as well. When you talk about cost considerations, again, this is all built into that pricing. Do you need to hire people? Do you need to buy equipment, reagent costs, IT costs? So there's, again, we have to figure out ways to be cost effective and be able to implement full population screening, and how this occurs varies from state to state, a lot of times based on the volume. As I mentioned earlier, there's newborn screening fees. So there's 5 programs in the US that have no fee. So they're paid out of either state funds or some kind of block grant or something like that, but there's no charge. Other states have fees that are either paid, bundled into labor delivery and paid to the state. Some states bill for the cards, the collection forms. There's different mechanisms for how fees are billed and collected. And you can see here there's a fairly broad range in pricing, but that's mostly because the fee covers different things in different states. So sometimes it's only the lab. Sometimes it's lab and follow-up staff and reagents and contracts for service and equipment and all of that. Sometimes it's lab and follow-up and the diagnostic evaluation. And other states cover lab follow-up evaluation and some medical treatments. And so medical foods and things like that. And so the variability is kind of built into what the actual fee covers. So 2021 was not unlike 2020. We had a continued global pandemic that really impacted us to move to kind of a new normal in 2021, but we were still kind of dealing with all of the issues you read about in the paper. I'm not going to go into, or on your iPad or tablet. We've also had some once in a lifetime disasters, things like ice storms that never get ice storms, hurricanes and weather incidents. We've had, one of our states had an explosion last Christmas. Very, very different state program, the lab, not the whole state, had an explosion. So different things that we really need to keep up with our continuity of operations. And babies are just born every day and everywhere, right? So we still have to maintain function. This has just an overview. There's 53 newborn screening programs. It's 50 states and some of the territories. There's a fewer number of labs because some are regional. And we have some that are also, the testing is actually done by a private laboratory. And this slide shows you the difference in births per year. So between 3,000 in the lowest birth rate state up to 419,000 in 2020, which actually is a drop in previous numbers. And some of these programs, including some of these large ones, require 2 specimens per baby. And so their testing throughput is actually quite higher. An interesting thing that programs observed across the state was that the birth rate really, really has dropped. So between 2019 and pretty much 2020, we saw a drop. For many years, we said there's 4 million babies born in the US every year. And now we're at 3.6 and change. And that really hasn't rebounded in 2021. We've seen a little bump up in New York, but our birth rate went from about 250 a few years ago. In 2020, it was 208,000. So think about the states that have fees and use that to fund their programs. This drop is basically a cut in the funding that funds the programs while they're being pressured to add more conditions. And so couple that with an increase in supplies and costs and plastics and everything else. And so this is a little concerning in the newborn screening world. On the horizon, there's always new conditions being considered. The advisory committee just voted to add MPS II or Hunter syndrome to the panel. They're now reviewing GAMT deficiency. We have CCMV coming on the horizon. Our last big emerging technology was tandem mass spectrometry, and that was back in the early 2000s. Now we're looking, and we've heard a little bit about this, some larger scale sequencing within programs. Again, I just talked about this and the continuing challenges that no one could have predicted a couple years ago. This is sort of a plug for New Steps. We have, they put out an annual report that's sort of the national picture on newborn screening. So you just go to newsteps.org, resources, and you can find their annual reports. And at the end of the day, it's not all doom and gloom. We continue to rise above and try to add disorders to our panels and do it in a high quality way. And we need just to keep the programs running. And so we've become creative in the last few years. So that's kind of the quick overview, which I hope Sika was planning to cover. And I'm going to turn it over to Suzanne, who you met, and she can tell you her quick story as well. Suzanne? Oh,
Thank you, Michelle. So again, my name is Suzanne Flynn. I am from New York. I'm a pediatric nurse, and I am the mother of 3. And I have benefited greatly from Newborn Screen. And I want to first thank Dr. Caggana for having me here today and for allowing me to tell our story and for the hard work that she has done in newborn screening. Back on March 29th, 2013, Aiden's Law was signed in New York State, which would begin, so newborn screening could begin testing for adrenoleukodystrophy or ALD. And somehow New York State Lab created a miracle because they were actually testing within the year. So our story begins on March 12th, 2014 with the birth of our Patrick, who was our 3rd child and 2nd son. He was a beautiful, healthy, robust baby boy, 10 pounds, 13 ounces. And he was our miracle baby after 4 miscarriages. So we were over the moon, and we took our baby home, our big baby home, to add to Charlotte, who was 7 at the time, and Gavin, who was 4, to start our family of 5. 2 weeks later, we got a call from our pediatrician to say that Patrick had tested positive on the newborn screen for adrenoleukodystrophy. But it was a brand new test, and it was a borderline result. So we were going to retest. So we went to the pediatrician's office. We did the newborn screening card again. It was sent off, and I honestly didn't think anything about it. I figured it's a new test. There would be margin of error, false positive. We had 2 healthy children and seemingly no family history of adrenoleukodystrophy. We went home, and then 2 weeks later, on a Friday at 7 p.m., our pediatrician called again to say that Patrick again tested positive on the newborn screen for adrenoleukodystrophy. And I knew then that, this was serious and that we were in trouble, basically, because I knew that the illnesses on newborn screen were rare, often devastating. I didn't know much about adrenoleukodystrophy, only that, in my eyes, it was a death sentence for our baby. So she told us we would have to go to Columbia first thing Monday for follow-up testing. And so that weekend we prayed, we hoped. I questioned my mother's side of the family to see if there were any boys who died of a mysterious illness when they were young. There didn't seem to be. First thing Monday morning came, and instead of going directly to Columbia, I actually called the nurse practitioner. And being a nurse myself, I was questioning her about what follow-up blood work, what that blood work was going to look like, and would we isolate the gene now and look for the gene mutation and the variant. And actually, she said, no, we have isolated the mutation. We've isolated the ABCD1 gene and see the mutation and have the variant. So I was blown away. I didn't realize that the screening could actually do that. I'm thinking this is 5 drops of blood on a card. But I realized then that it was not just a simple screen, that it was, more complex than that. But I was, to say the least, devastated. And I knew to be worried for my Gavin right away, because I did know that it was genetic, and I knew that it affected boys more significantly than girls. And I said to the nurse practitioner, I have a 4-year-old son. And she said, we have to bring him and we have to test him as well. So I called my aunt, Meg, who drove us, because my husband and I were in no condition to drive. We were, beyond upset. And I also called a friend of mine, Nurse Nancy, basically to tell her what was going on. She already knew. She worked in our children's pediatrician's office, but and she said, I'll meet you at Columbia for the appointment, which I think was a great thing, because I'm not sure what I took in at that first appointment, because it's just so overwhelming and devastating. So she was another pair of ears, and she could take in the information and relay it to me after. And I remember her saying, you know what, we just have to get the information. Knowledge is power. And, we'll use this to make sure Patrick gets the best care. So we went to Columbia. They drew bloods for the baby, Gavin, myself. They sent the genetic testing to Baylor. They sent very long chain fatty acids to Mayo, and they even started our extended family. My brother came down and they tested him as well. They did give us information about, types of specialists that they would, that Patrick would need to see. And, the surveillance testing of the MRIs every 6 months, from the time he was 1, and then MRIs once a year from the time he was 12 and all the way, for his entire life, which seemed impossible, absolutely impossible to me at the time, that we would be able to live this way. And they did give us the contact information for Dr. Raymond, who was, one of the leading specialists in ALD. So while it was new, they did a lot of good things right in that first visit. Even though for us, it was just such a devastating diagnosis to get for our newborn baby. So we went home. We did start reaching out to these specialists and making appointments. But then 2 weeks later, we did get the phone call that Gavin also had ALD. And I was clearly a carrier. We all had the same mutation, the same variant. And because Gavin was 4.5, he was in that critical time frame where children develop the cerebral part of the disease, which is the most dangerous. So the very next day, on a Wednesday, I remember, Gavin had his very first MRI at Columbia. And we overnighted the disc to Dr. Raymond, because it is important to have an ALD specialist read these MRIs. And in the meantime, we saw the neurologist at Columbia, who thought that Gavin's MRI did show demyelination, and that he said we should start getting prepared for a bone marrow transplant for Gavin at that point. So the next day, I remember, was a Friday. I took the kids to the botanical gardens, the New York Botanical Gardens. My friend urged me to go. And I remember thinking, like, I do not want to go to the botanical gardens. I would rather set myself on fire, because that would be less painful than what I was experiencing in that moment. But I figured, you know what, these are my children. I have to raise them and make their childhood good, no matter what challenges we were facing and about to face. So we went, and while we were there, Dr. Raymond called us to say that Gavin's MRI was normal, and that what they were seeing was not demyelination, but something called terminal myelination or immature myelination. And I realized at that point, in such a beautiful place like the Botanical Gardens, that this diagnosis through newborn screen was a gift, and that Patrick coming at the, being born at the time that he was born, and to be able to be picked up on newborn screen and get an early diagnosis of adrenoleukodystrophy was such an important thing. And it helped to diagnose his older brother and essentially save both of our children. So at that point, I realized, this is a gift. We are grateful, and we are going to make good with this diagnosis. So we assembled our healthcare team. We did travel to Minnesota to see Dr. Raymond. We also traveled to Kennedy Krieger. And then finally, about a year and a half, we saw Dr. Eichler, who is in Boston, and we decided that is where we would do all our follow-up, and the boys would have their MRIs at Mass General Hospital every 6 months and see Dr. Raymond. And this is what we have been doing for the last 8 years, monitoring our children and being ready to intervene at the earliest possible point to ensure that they get to live, a healthy, happy life. This is just a picture of my Gavin and Patrick, and this is the day of an MRI. So they've had their MRIs, and then we chartered a boat. And I feel like this really captures our life with ALD, oddly enough. But the children are thriving, they're healthy, they're happy, they're doing well. They never complain, they're happy to get the MRI. Children are so resilient. We underestimate just how resilient they are, but my boys are so joyful. And they're wearing their Aiden has a posse t-shirts, which without Aiden's law, the early diagnosis would not have been possible. And, we were, in the beginning, I feel like it's important to mention that this was 8 years ago, and newborn screen for adrenoleukodystrophy was new. Patrick was the 5th baby picked up on newborn screen in New York, and Columbia's first referral. And while they did connect us with Dr. Raymond, which I think was the best thing they could have done, because then from there we were able to find specialists, and my pediatricians did research. But now, 8 years later, it's different. And when families are getting this diagnosis of adrenoleukodystrophy through newborn screen, we have resources for them, and they will get a parent's guide, which I have here. This is the parent's guide that they will get at diagnosis. And this has all of the resources that you need. This has the specialists. This has also ALD Connect, which is a wonderful resource for families. And that is where you can find all of the clinical trials. ALD Connect has a mentoring program for new families. And we also run support calls once a month for new families who have received a diagnosis of adrenoleukodystrophy through newborn screen. And I will tell you, I help run the calls with 2 other moms, and on the calls are moms whose babies are 1 month, 2 month, 3 months, and they are already light years from where I was at that point 8 years ago. So just having the resources and the tools to start this journey and get the support you need and be connected with the specialists right away has made such a difference. And also some biotech companies, Bluebird Bio came out with their own guide for adrenal leukodystrophy, which I have here, and they have a lot of information on their website. ALD Alliance is the one who came out with the parent guide. So there is just so many resources out there, and so many things that have been accomplished because of newborn screen, because families are getting this diagnosis early, and we have the opportunity to monitor our children and intervene at the earliest possible time. And because of this, you can see my boys are thriving. So this is a very hopeful picture. And I hope that when, the specialists give these diagnoses to families through newborn screen, that, you are able to frame it for them that this is a hopeful situation. You are getting this early diagnosis for a reason, for, to help, it is the early intervention that you need. It's the knowledge that you need to keep your children well, and knowledge is power. We all know that. And it's just a hopeful picture, and we are so grateful to the New York State Lab for their hard work. We're so grateful to Elisa Seeger, who fought to have Aiden's Law in New York State. And we're just grateful for this early diagnosis and the opportunity to save both our boys. Thank you.
Sure, I'm unmuted this time. Thank you, Suzanne. Thank you for sharing your story. It's always, to hear parent stories is just really good for all of us that are the lab monkey parts of the process, or the newborn screening programs. So I appreciate you sharing your story with the group.
Yeah, I'm honored to share my story, and for you to see, the real face behind the newborn screen, these two beautiful boys who are now doing so well and thriving and having a wonderful, healthy life. So if you could put a face to all the hard work that you guys are doing, I think it's so important. So thank you so much.
Appreciate that. Okay, so we have a few questions for the panel, and we're going to just ask for your different perspectives as you come to newborn screening from different angles. So the first one is, one thing that we try to always emphasize is that newborn screening is truly screening, right? So talk about how the difference between a screening test and a diagnostic test from your different perspectives. So maybe Beth, you can start.
Sure. So the technical perspective is a screening test means your child could or could not have the disorder. From a technical perspective, it means you are your child is or you, if it's screening test of you, are at elevated risk. It's like the same. I use the mammography example because many can relate to it. Like when there's a spot on the mammography, many women also can relate to it. It doesn't mean you have breast cancer. It means the mammography saw something that could be a cancer. And then you need an additional testing, which we call the confirmatory testing, which then is done to say that is the definitive, as we say, the conclusion of whether or not you have in that case, breast cancer. And so usually that happens as two separate events for people. It's two separate kinds of tests, two separate experiences. Some parents some individuals are like, I don't get it. I had one test said it was something and the other test said it was not. What's that mean? How do I know which one is right? But in sort of the medical and technical parlance, we do this staging of screening because the first test is sort of easy. The screening is easy to roll out. It can be done at a mass level. We can do it to all people relatively easily and relatively less costly. The second test we reserve for those people who were quote unquote out of range, trying to do labels like positive or negative or effective on the first test. So that's why you see these two different tests and how they roll out. And in newborn screening, the challenge is sometimes the parents don't see the two tests, just like we were talking about. Sometimes there's actually more than two tests. The mammogram is simple, right? The mammography is one. Sometimes there's two tests and we get you at a higher level of risk. And we still do another test that you see. Sometimes sickle cell is a good example. I remember sitting in my clinic getting a test result positive, quote unquote, for sickle cell disease. And it was sickle cell disease. The kid actually ended up having sickle beta thal. And so I said, but it's a screening test. I put on my physician hat and I was like, it's a screening test. It can't be positive. You have to do a definitive test. You can't say the child has a diagnosis. And the sickle cell director said, I'll buy you like a bottle of champagne. It's going to be positive because technically the screening test was so accurate and likely be predictive. But that is a general unusual, extraordinary case. It's generally the screening test does not mean your child has a disorder or condition. It means they could, and they're at increased. My husband always knows to call me like when these times occur. Is your child is at possibly increased risk or could have it. But we say these things, and like Suzanne said, like the understandably, like I had a cancer diagnosis, and if you're like, oh, I'm like, no one's like, you're not hearing these things. So from the provider standpoint, it's incumbent upon us to repeat, and also ask the parents to ask the questions. I'll stop there.
Thank you. Anyone else want to chime in on that?
This is Bob Ostrander, and that was perfect, Beth. One of the things that in terms of explaining how screening tests are devised, I think is helpful for people to understand the difference. Screening tests are devised never to miss a case, or almost never to miss a case, which means you get more potentially false positives. And then the confirmatory test is designed to make sure that it's really right. So that's why you can have a screening test that's abnormal and have the confirmatory test not show it, because we set a cutoff marker for the lab results, and we set that bar super low on the screening test so that we try to catch every possible kid who might have one of these newborn screening diseases. And then once we've got that smaller group that might have it, then we do a more detailed test that tells us who really does have it. So that's kind of a different way of explaining the difference between a screening and the way the tests are designed. But I really think, honestly, our best example is what Beth did, which is the one I always start with, which is the mammogram example, because everybody, people understand that that's a screening test, and that a lot of the abnormal mammograms, because you don't want to miss any cancers, are abnormal mammograms, but they don't show cancer.
Yep, thank you.
I would say from a follow-up perspective that it really is, a newborn screen is a snapshot of a baby at one point in time. So we frequently receive calls from providers who have clinical concerns about babies, but they have a normal newborn screen, and we have to educate them that a newborn screen is a screen. If you have clinical concerns, you need to do diagnostic testing, even with a normal newborn screen. There are some later onset variants, even with some of the tests on the disorder that may not be detected with the newborn screen. And then, like, for example, Virginia just recently started screening for SMA or spinal muscular atrophy, and our testing is only expected to catch about 95% of the cases. So there's 5% off the bat that we know that we are not going to catch. So it's important to know and have that education and conversations with your stakeholders.
Thanks, Kristen. So continuing on that line, I guess, so I tried to kind of say in my talk too that newborn screening has this odd component. When you're a clinician and you order a diagnostic test, you get a result. Nobody calls you from the lab later on to say, hey, was that result true? Did it work?
And the person usually has symptoms.
Right, and the person usually has symptoms if a clinician orders a test. So Kristen, you want to talk about follow-up and sort of how it occurs in your shop, and sort of how it impacts the ability to add conditions and that sort of thing?
Sure. Again, every state does follow up a little bit different. When I talk about how we do things in Virginia, it may not be done everywhere. But I would say one of the key components of follow-up is education. It's providing education to both our internal and external stakeholders, including our families. So we do provide education to our families, but also when we do have a critical or out of range result from the laboratory, that we're able to get those results to the follow-up provider, to the healthcare provider, the community provider, whoever's taking care of the baby at that time, and the appropriate consultant, as opposed to waiting to when all the testing is done. So in order to have more expedient intervention, so I manage a team of nurses that do call out those results, as well as with guidelines for next steps for diagnostic testing, whether to speak of genetics or to order these diagnostic tests depending on the disorders. And as far as thinking about from a follow-up perspective, it is the only universal public health screening program. So it is equitable to have all babies screened, but we also want to think about, like, clinically, does the benefit outweigh the potential harm? So if there's a really high false positive rate for the disorder, this is going to cause a lot of diagnostic testing and a lot of parental anxiety of getting the call. So that is something that we look at when we're considering adding a disorder to our panel, as well as what treatments are available. We're not necessarily looking for a cure, but is there a treatment that's going to improve the quality and outcomes of the baby's life? And looking like state specific, do we have treatment available in Virginia? Because that's going to cause a issue in care if we had to send the baby out across state lines to receive treatment. Yeah, I think that's all I have at the moment. Is that okay, Michelle?
Yeah, definitely. Dr.
Okay.
Stewart, do you want to, just from your perspective, when you get that phone call?
Yeah, over the years, I've really viewed it as an opportunity to connect with families in a positive way, and to try to turn a potentially very stressful experience into just a connection all about their baby and about how many of the babies do have very positive outcomes, and an opportunity to educate them about the program, because I've had many patients whose screen actually ended up being okay, but they reached out for an unrelated sibling or another genetic problem or a question many months later, and still I find it a success if they can remember that interaction as positive and remember why we do newborn screening. So I think that the positive approach to that first phone call in any small way, and the friendliness, making them feel cared for, is the most important thing. And that initial phone call is going to be everything, that initial first time connection with the family.
Thank you. Miriam, do you want to talk about how your state works with follow-up, how that is coordinated?
Sure. So in New Jersey, the laboratory and our follow-up program are located in two different spots. We're about a 10-15 minute drive from each other. But that means that we do a lot of communication, and we communicate with our follow-up group on a regular basis. Almost every day we're talking to them. We're sending emails, we're picking up the phone, we're calling them. Whenever we in the laboratory have a critical result, we immediately call that over to our follow-up group. We don't wait for all the testing to be completed and for a next report to be generated. We call it over immediately to follow up, to let them know that this baby has tested positive for this disorder. And immediately, and we actually continue to email them information, even though we now share our computer system is shared between the lab and the follow-up, so we all view the same thing. We still send them an email directly with all the information that they need about that positive result. We call them right after we send that email to make sure that they've received it, and confirm that with them, and then they get to work right away, and they reach out to the physicians, the specialists, the families, to get them all connected. And on the laboratory side, for some of our disorders, we don't get positive screens very often. So when we get a positive screen, we're like, oh, it's a positive screen. And then we all say to each other, like, well, there's a baby at the end of that. Every specimen that we test is a baby. And we kind of take a step back and we say, this is great that we have a positive screen. We know that we are about to profoundly change the trajectory of that baby's life and that family's life.
Thank you. Thanks. Suzanne, when we talked a bit in the beginning, we were you talked about sort of getting that the variant and the fact that you did not have resources, and sort of from your perspective on the follow-up side, what can programs do better to make your experience, the parental experience, better?
I mean, again, it was so new. So I'm certainly not critical of the follow-up that we got. I feel like Columbia did their very best. They did start to make appointments for us. It's, for specialists. They did all the follow-up blood work, and they did already have the gene variant, the mutation, but they confirmed it with Baylor, and for the baby and myself and Gavin. And they did put us in touch with Dr. Raymond, which I think was so key to sort of right away we could reach out to an ALD specialist, which is so important because you saw the difference. The neurologist at Columbia, even though so amazing in his own right, thought that Gavin's MRI showed demyelination, whereas then Dr. Raymond, the ALD specialist, was able to tell us, no, this is a normal MRI. So I just feel like a lot of our experience was just because it was new, but Columbia did a lot of things right by giving us, but I feel like they just didn't really know. There was a lot of, we don't know what this means. We don't know. So that was a little hard, but, and you are changing a family's life, really for the better. I mean, with regard to adrenal leukodystrophy, for the better, because the difference between not knowing and knowing early on and intervening is really the difference between devastation, disability and death. So it's so important. You're changing this family's life, but you're also devastating them at that point too. And I feel like it takes a little while to sort of accept this, process it, get your sea legs, so to speak. And I feel like I see a difference in the moms, the newer moms, because they're getting the resources, they're getting the support, and they're doing better early on. Whereas I feel like it took me so long, to like 2 years to get my sea legs with this ALD. But they're doing a lot better because they have the resources and support right away. Like I said, ALD Connect has a mentoring program. We have support calls that are monthly. So I just feel like it's important to right away get this hopeful picture that this is on the newborn screen for a reason, that to benefit your child and your family, just to give the family a hopeful picture and the resources they need to go forward.
So we've had some talks today, thank you. So you had your DNA variant because our program actually sequences the gene, and there's been a lot of bubbling about having sequencing part of newborn screening, and that fuzzies there's a comment here from Raylan Forsyth saying that it sort of fuzzies the water a bit between screening and diagnosis. What's your feelings I guess we'll go first with the clinicians of getting that information at that point, and how does it help with universality? Do you run into fewer issues, more issues with a DNA result as well?
I could maybe answer that question. We feel very strongly, and we've written about MPS1 screening in particular in DC, but we feel very strongly that it is an access and equity issue to be able to have the DNA testing to confirm a result as soon as possible for families. It can lead to faster answers, less barriers to care with insurance, and all sorts of follow-up. And I do feel that you, Michele, and New York State has been a leader in advocating for this earlier. We're very grateful. I know Virginia, other states are also doing a lot of great work on this, but it really has made our process for both the clinicians and patients more equitable, gives them answers sooner, gets them the information they need in very high stress situations.
And to add to this, because of the DC the issues. You know, there are some times in which, to Bob's earlier point, we're designing these screening tests with the best we can identify as the sort of, these are the people we want to, these are the kids we want to take out and test. We think this is where the boundaries are. But, you know, these are rare diseases, and we know about them because of people who presented, children who came with symptoms, who themselves, their own separate group, really unique, because they have severe, they came to us, people were like, something's wrong with this child. They do not necessarily look like everyone else who might have the disorder, and or other people that might have the same test results that don't have the disorder. And I think the MPS 1 is an example where after a period of time taking these tests into the population, you begin to see that we might be finding these quote unquote benign variants, like what we thought was an indicator of disease in most people or condition is not. And if we had the benign variant knowledge, if we could do those tests, those DNA tests, we could spare a lot of people who really weren't, this was what we didn't know was a benign variant. It like, and these come up in populations that are, you know, I'll use example, the Hmong population is the one that commonly, Native Alaskans, populations that are, that may have because of, they call it the founder effects and things like that. Just it's a matter of population genetic dynamics, and we didn't know that. And when we don't have that information and can't do that right away, we're pulling in all these other people who it was sort of an accident of genetics that we pulled them in, not because they really were at risk. And that really, and the DC example that Dr. Shore is referring to and has been written about, it is really important to sort of hone these programs. And I know there are people like Dr. Caggana that work hard to sort of iterate on this, but I mean, this information is dynamic and continually changing.
Erin, what about from the lab perspective and sort of the whole timeliness perspective with adding a sequencing component?
Adding a sequencing component can be a challenge. I think it is a challenge. It depends in part on what resources with your staff you have within the laboratory, because sequencing is something completely different from a lot of the other tests that we do. It's a different technology that not everyone has the background and experience to be able to run the laboratory test. So if you don't have that experience within the newborn screening laboratory at the outset, then that's something that you would need to bring into the laboratory before you can start planning to do sequencing. In addition, it requires not instrumentation, so all of the challenges that come along with purchasing new instruments, validating a new assay, so making sure that your lab test is working the right way. Those are all challenges that you face as you bring on any new assay, but specifically with sequencing as well. Sequencing is also unique in that you can do the laboratory part of the testing, and then you come up with essentially a list of variants that you think that test shows this baby has this variant. Well, what does that mean? And you really need expertise to do that interpretation as well. And again, that's something that not all newborn screening laboratories might have in-house to be able to do that interpretation aspect. And then finally, when you're adding in something like this, it does add additional time. So it may add a couple of days to do the sequencing, another day to do the interpretation. So it does add to that timeliness component. We're trying to get results out as quickly as we can, but by adding in a sequencing component, we're acknowledging that getting out the results will take a little bit longer. Is it worth that trade-off? Are we providing the clinicians with critical information still within that appropriate time frame where it's worth spending the extra couple of days within the newborn screening laboratory before we pass it on for clinical evaluation?
And I'd also like to jump in and say, from the follow-up perspective, I feel like the absolute worst thing to do is call a doctor at 4:00 p.m. on a Friday with a sequencing, a variant of uncertain significance on Friday afternoon. Even if you tell them, please do not contact the family until Monday, genetics is going to needs to reach out. They're going to turn around and immediately call the mom. Mom is going to be anxious, Googling, and of course, when you go to Dr. Google, it's going to give you the absolute worst case example of the disorder. And so my follow-up team, we will triage, and if there, I mean, nothing's going to happen over those 2 days as far as testing, like specifically for like the lysosomal storage disorders. We will triage and we'll hold them. If we receive a homozygous pathogenic for Pompe and the baby had some, cardiomyopathy, that would be a different story. We would reach out to the consultant and let them know about that. But for like a VUS or something like that, we absolutely would not report that out, because or even like I've had a CF.
You froze up.
Oh, I'm
Okay.
sorry. Am I back? So I've even had a pediatrician call a homozygous Delta 508 mom for cystic fibrosis on a Friday and just say, oh, yeah, your baby probably has CF. You need to make an appointment and go on a Monday. And that's all they told them. So I was on call Friday night and she called me and was on the edge of a cliff, and she thought her baby only had a lifespan of like 10 years. No education was provided. And so I feel like follow-up provides a lot of that education and reassurance the prior to them getting into the consultant, and also making sure that connection occurs, making sure that they get the diagnostic follow-up testing, that they get in the office with that doctor, whether we need to contact the mom to make that happen, or the parent to make, or the provider to make that happen, but make sure we do the follow through and follow up, even if it ends up being everything being normal, just doing our due diligence for that.
Great, thanks. So it was posted in the chat. The session is formally over, but we have a few questions. If you can stay on, I don't know if our specialists and our panelists can stay. One was for Suzanne, how you found your experts. I know you were referred to Dr. Raymond, but how did you find Dr. Eichler? Was that through Dr. Raymond or?
That was actually through our pediatrician.
Okay.
They did a lot of research for us. Because our pediatrician is in New York City, I have 3 really smart women as our pediatricians, and right away they did a lot of research. And I'm a pediatric nurse. I worked for them for many, many years. So I feel like it was like a family affair. So they started the research right away. I did get a phone call at 7 p.m. on a Friday, but because the pediatrician did get the call, and I think she, I think she said, I better call Suzanne. She will kill me if I wait till Monday morning. But also I just thought it was helpful for me to start processing. Again, I didn't realize that they had the variant, that they could see the mutation, but getting that information that Monday morning for us, I felt like was important, because then we knew Patrick had ALD, and we knew to look at Gavin, who was already, he would be high risk for that, and he was already at a critical age. So I felt like that was important for us. But our pediatricians did a lot of research for us, and I feel like I'm a pediatric nurse. I had savvy, med savvy friends who could really help me. And so not everyone has that. And I feel like that's why it was important for the ALD community to establish, the parent guide and the standards for follow-up, because not everyone is from 25 minutes outside of New York City with, pediatricians as friends. So, I could hardly navigate it myself in the beginning, because I was so overwhelmed by the diagnosis. So they helped me until I was able to get my sea legs, essentially. And I feel like that's not going to be the case for many other moms. And so we do need to educate the mothers. We do need to have resources for them right away, and have the specialists for them, and help to establish that right from the beginning for them, because it's a very stressful situation, and you're overwhelmed, and you're not really taking in information properly in the beginning. So I just think now we have it established, you know, the resources are there and they are able to get in touch with ALD specialists, and we can figure out what part of the country you're in. A lot of times the moms, we do go out of state to see an ALD specialist. But that being said, if you cannot go out of state, ALD specialists will read the MRIs. You know, they're happy to do that, but you have to get to the right people, and you have to give these parents the right resources and the right specialists.
All right, thank you. So I don't know, Anna, what do you think we're doing on time? Do we have time for one more question, or do we have to wrap up?
I think it depends. There's 7 minutes left of the break. So maybe one short one, and then let people stretch a little bit, breathe between the next session.
Okay, so there's one from Julia. She says that maybe this is more for maybe Miriam. Some states are turning to private labs for first-tier newborn screen and others for second-tier screening confirmation. What downstream effects do you anticipate from this kind of a model?
So there are states that contract out their first-tier testing, and then there are states that do their first-tier testing within the state newborn screening lab, but contract out to do second-tier testing, which is a great answer, I think, to not having the expertise in-house and not having the ability to build expertise in-house. It has some logistics attached to it, in that you need to figure out how you're going to send the specimen from the newborn screening lab out to that second lab. It may have some challenges in terms of, is that something that's okay with the department that you work in to do? Is the Department of Health supportive of sending samples out to another laboratory? Those kinds of questions would come up, but I think it's certainly something to consider if you're not able to bring the expertise and the technology in-house, is to send out to an external laboratory. And it could be a private laboratory. There are other state newborn screening labs that will test specimens for other states, and I think that's another model to look into as well.
Yeah, I agree. I mean, I sort of echo that with the lack of expertise, and then we're looking at timeliness and logistics and being able to have specific screening, so we don't have a lot of false positives, but we still don't have false negative babies. It's very, there's a lot of models out there that are floating around, and maybe we'll land in a nice sweet spot that benefits the families. So I wanted to thank you all, and thanks for everybody that hung out with us. Most of you hung out with us, so I appreciate it. I saved the chat, so if there's anything that comes up, that I can address to the panelists and get back to people, I'll do that for you. And you have all of 6 minutes to stretch your legs and run to the bathrooms. We'll see you in the main session. Thanks so much to everyone for your expertise, and to Suzanne for sharing your story and taking the day off to hang with us. So I appreciate it.